Good afternoon. Welcome to AIG Hospitals, Gachibowli. I'm Dr. Srinivas Thati, Head of Department of Trauma and Orthopedics and Sports Medicine. With me is Dr. Rajesh Rachha, Senior Orthopedic Consultant. Today we welcome you on this World Osteoporosis Day. October 20th is celebrated as World Osteoporosis Day to improve the awareness. Me and Dr. Rajesh Rachha will have a discussion on what is osteoporosis, how is it diagnosed, and the treatment, what options are there. So, to start with, I would ask Dr. Rajesh, can you please explain what is osteoporosis?
Hello, good afternoon, everybody. Osteoporosis is essentially is a decrease in the bone quality. Overall bone quality is decrease in the bone mass itself. It is a microarchitectural defect in the bone. So the architecture of the bone, which is like a good meshwork system, as the age advances, as the age progresses, this meshwork is disturbed and it becomes very weak. The bone mass decreases, and thereby it causes more weakness of the bone and susceptible to fractures. So in short, it is the decrease in the bone mass and the overall quality of the bone as one advances in age.
When we think about the bone, histologically, it has two important components, like the mineral component and organic component.
Okay.
So in the osteoporosis, it is not just the mineral component. Most of us think that's just the mineral. No, it is the overall, both organic part and the mineral component. Both will reduce in the mass.
Okay.
So we commonly see this condition, and certainly it is a silent disease.
Yeah.
And most of the time it goes unnoticed. So what are the symptoms do you recognize?
Yeah, this is something really important because unless we look for it, we don't try to diagnose osteoporosis as such, because as Dr. Thati is mentioning, it's a silent killer, and we don't, the patients won't present to us unless they land up having one fragility fracture or fracture of the bone. Otherwise, essentially, patients are they look hale and healthy without any symptoms. But if at all, symptoms could be, sometimes they can have essentially some backache, vague backache, generalized weakness in the body, and bone pain sort of a thing. But most of the time we see they have a trivial fall at home, even from a standing height or something like that, and land up having injury and fracture. And when they come to us, when we look at the x-rays, then we see that the bone quality is very poor. So most of the time, unfortunately, we see them when they actually present with the fracture.
Correct. So when we think about the incidence of osteoporosis, after the cardiovascular diseases,
Yeah.
osteoporosis is a very common problem.
Correct.
Most of the times we measure this by peak bone mass. As any adult, we achieve the peak bone mass when we are around 25 to 30 years of age. Interestingly, the Asian population, they have attained the peak bone mass a bit later compared to the Western population. And when we look at how we lose the bone mass gradually over a period of time,
Yeah.
suddenly there is accelerated bone loss in the women, particularly
Correct.
post-menopause.
Yes.
So in the past, there was a lot of emphasis on hormone replacement therapy, etc., to reduce the risk of osteoporosis in women. But it's also interesting to know the incidence in men. So
Yeah.
every 1 in 3 women is known to have osteoporosis after 50 years of age.
Yes. Is quite increasing in male population as well. So if you look at global scenario, 1 in 3 females above 50 years of age and 1 in 5 men above 50 years of age are suffering from osteoporotic fractures. So, and the incidence is almost 8 to 9 millions population are suffering from osteoporotic fractures per year, which is like one person every 3 seconds is sustaining osteoporotic fracture globally. So it is a serious health issue. And compared to Indian scenario, the when we compare to the Western counterparts, the osteoporosis, say for example, one attains at say around 60 years of age or 65 years of age in Western population. We are seeing 10 years earlier to that age group in Indian population. So at 55 itself, we can in Indian population we are seeing osteoporosis because of probably various health style changes or environmental changes and overall general health when compared to Western population. It could be environmental factors, genetic factors, or food factors. A lot of things are there, but that's the seriousness of the issue when Indian population are concerned. Yes.
So relevant, right?
Yes,
Compared to Western
Western
population. And when you look at the risk factors, I think we can define them as
Yes.
something which we can modify and
Okay.
something which we can modify. So the non-modifiable risk factors are certainly the age.
Age.
As you're aging, your bone mass goes down. The second one is family history, and unfortunately, women are at higher risk because of the hormonal changes they undergo.
Yes.
Ethnicity-wise, we are at a higher risk compared to the Western population. So, how about the modifiable factors which we commonly come across?
The modifiable risk factors are mainly our lifestyle changes, essentially, like maintaining a healthy weight and then having a proper diet rich in calcium and rich in other elements like magnesium, strontium, etc., vitamin K, which are all readily available in food sources. Vitamin D is a very essential component for healthy bones in order to absorb the calcium, which is again readily available with sun exposure. So these are some of the modifiable risk factors. And in patients who are consuming excess of tobacco and alcohol, so if we cut by cutting down them as well, we can prevent damage to the bone. So and if there is already a family history of fractures before, or if a person already had a risk of fracture, the fracture risk increases tremendously. So that has to be addressed, and definitely that is preventable even before we start any pharmacotherapy or medical therapy. So it is the preventable. There are many, though age we can't obviously stop. Aging process is one thing, but we can definitely prevent the weakening of the or softening of the bone by other means as well.
Absolutely. So one of the other issue is most of the patients present with a fracture, and when we look at the incidence of fractures, the most commonly fractured bone is the spine.
Yes.
And almost 27% of these fractures are in the spine, around 14 to 15% in the hips, which can have significant effects on the patient's health. So even before presenting with a fracture, how can we recognize these patients early on so that we can start the treatment?
So one is as identifying the risk factors. Of course, one is the age. So every patient above 65 years of age, every person above 65 years of age is prone for osteoporosis. So we need to monitor them, or if needed, need to be tested for osteoporosis. And likewise, the other risk factors which we just discussed. So if any of those risk factors are there, then it has to be tested. Or if there was a younger patient who had a trivial fall and had an injury, yes, that's again an indication to test them earlier on. So X-rays alone is not it doesn't give us enough information, because by the time we get an X-ray and find that there is a bone loss, that means already 40% of the bone has lost to diagnose on the X-ray. So the best means, or the gold standard at the moment we have, is what we call as a DEXA scan, which is a dual absorption X-ray. It's a kind of X-rays, but it is much more modified than our regular X-rays, which a patient goes through a scanner. It hardly takes about 15 minutes for the for the results to come. And it actually measures the mineralized bone at one particular area where it is checking. Like say, most commonest sites we check is at the spine, the hip, and the wrist. Those are the commonest sites. We get this bone mineral density by means of DEXA scan, and that gives us how much. It gives a kind of a scoring and graphs which will tell us how much bone loss has happened, and accordingly we can take an action to revert that osteoporosis. And there are other modalities to check as well, apart from the history and the risk factors. We can, depending on patient specific, the other modalities are like you can get CT scan, ultrasound scan, MRI scan. There are other things, but these are not very commonly used. But the DEXA scan is a gold standard, readily available, readily done, and that gives enough information. Along with the DEXA scan scores and the clinical risk factors. As a clinician, as a doctor, we prescribe what needs to be done, preventive measures and definitive measures in the form of medication, etc.
I think when it comes to, because it is difficult to identify the condition, screening program using DEXA scan as a simple means can help in diagnosis of a lot of patients. So I don't think we follow a certain screening protocol, but anyone over 50 years, females over 50 years, or who are very close to menopause, better to get a screening DEXA scan done, which will give us the scoring. The way we score is based on the DEXA scan. It gives a T score, which is age matched, peak bone mass, and based on that, if the number is low, then the patient can be started with the treatment. However, in men, I think over 65 is a safe number of age where you can start doing the screening. So, simple DEXA scan is very useful in identifying or diagnosis of osteoporosis. And some patients can have what we call as osteopenia, where the bone mass is less than actual disease. Even osteopenia in certain patient groups who are at high risk may need treatment. The other important aspect when it comes to osteoporosis is it is a diagnosis of exclusion rather than a diagnosis by itself. So some patients may need investigations like doing the routine blood tests, CBP, then the calcium levels, parathyroid hormone levels, and also vitamin D, B12. This will give us a fair idea if there's any secondary causes for osteoporosis. And the other important aspect to identify is to screen the patients who are on these medications, like long-term steroids, those who are on long-term phenytoin for epilepsy, and those who are on chemotherapy. All these patient groups who are taking regular medication, they also benefit from screening. They can get DEXA scan.
Yes, essentially all those, the awareness is important, first of all, and all those people or the patients who have risk factors, especially if there's a family background of rheumatoid arthritis, for example, or patients who are on steroids, they would already know that they would already been informed that you are on steroids or you have this particular disease, so you are prone for osteoporosis. So they needs to have routinely checked in the form of DEXA scan and other blood tests, and also as simple as most of the gastric patients who are on these antacid medication for a prolonged period of time, even they are also prone for osteoporosis. So they can also be checked with a simple DEXA scan along with calcium, vitamin D, and other minerals, and that will give an idea, and thereby coming for further management to your doctor, and they would be able to give the appropriate medication to that particular patient and prevent further damage to the bone and fractures, essentially.
As we enumerated the preventive measures,
Correct.
like particularly the lifestyle management, exposure to sunlight, doing some regular weight-bearing exercises,
that is important.
joint loading exercises, and the other important aspect is the treatment part. And we usually start treatment even in patients who have, as I said, osteopenia with some other risk factors. The two major parts of the treatment. One we use as anti-resorptive treatment, the other one is bone formative therapy.
Correct.
So, how do you go about?
Yeah, first and foremost, we'll obviously try all other modalities. We inform the patient, including exercise. Weight-bearing exercise is something which we want to touch upon as well, because most of the patients ask us, what are these weight-bearing exercises? So, any movement against gravity, sort of a thing, like say walking, mild jumping, or taking stairs, and gentle dance, and little bit of weights, free weights, etc. They're all weight-bearing exercises which will stimulate the bone cells and forms the bone. So that is the crucial thing. And some balance exercises like yoga, etc., are the key. And supplements like calcium, vitamin D, which most of the time these supplements are available in the food sources. If they're too low, then it's better to give calcium and vitamin D supplements in an oral form and a tablet form. Now, coming to definitive treatment, as we were just saying, two types of medication we have. One where those medications they prevent bone breakdown, like anti-resorptive medication we call them, and the one we call them anabolic medication, where there's a bone forming medication. So depending on the various factors, as we have already enumerated, like depending on the T-score and depending on if they already had a fracture. So if the T-score is very low, like say we have numbers like say minus 2.5 and lower than that, along with a fracture, for example, then it needs a very aggressive treatment. So they need to be on both anabolic treatment, which is bone forming medication, as well as the anti-resorptive medication. So one is in the form of tablets, and sometimes most of these anabolic medication are in the form of injections. So if you know, just there are these two types of medications. We don't want to go into details about the individual injections as to how, but just to make a mention, they are called teriparatide injection, which is like a parathormone injections, which you have to take subcutaneous. It's like an insulin sort of an injection, daily one shot. You take for almost up to 1.5 to 2 years, and along with an anti-resorptive medication. Again, there are some injectable forms as well as oral medication. Some are taken daily, some are taken weekly, and some are in the injectable forms taken 6 monthly. So there are various mix and match combination depending upon the patient and depending upon the severity of osteoporosis, depending on the risk factors, so that are assessed by the doctor, by our orthopedic surgeon, or by rheumatologist, endocrinologist. They're all are the doctors who treat this osteoporosis. So we assess a particular individual who would benefit from a particular medication, because these are medications also have got, like any other medication, have got side effects, etc. So we assess the patient who needs the best treatment. So overall, the management, can range up to 3 to 5 years, and keep checking, and they definitely help in bone reformation. So we keep again getting a DEXA scan at least once in 2 years to see how the bone is forming. Then we give a kind of a drug holiday for some time, and again recheck and again restart. So that goes on, this type of medication. But these now the current medications are really good, and they do help in reverting the bone mass to better quality bone.
The important thing to understand about osteoporosis is it is a aging process. It's a part and parcel of the aging process. One thing I want to emphasize is that there is no cure for osteoporosis, but we can treat the osteoporosis so that we can prevent the complications. Whether we take all the measures, still we are at risk of losing the bone mass because of the aging. But what we should ensure is that our bone mass is maintained to the optimal limit to that particular age. That will certainly prevent the complications associated with osteoporosis. And the other important thing is early we diagnosis the osteoporosis. The treatment is a bit more simpler in the oral form. You can supplement with diet, vitamin D, calcium, etc. But as the disease progresses, then the treatment becomes more injectable forms and it's a prolonged treatment.
Yes.
And unfortunately, when it comes to bone formative therapy, there are no oral formulations.
Correct.
And sometimes we see clinicians may go on the side of giving a bit of anti-resorptive therapy instead of anabolic treatment.
Yes.
That may not be the right thing to do.
Yes.
And if the patient's bone mass is really low, I think it's better we focus on giving formative therapy or anabolic treatment with a teriparatide, even though you have to take it for a long period.
Long period of time.
The other injection, monoclonal antibody variant denosumab, is also available, which can be given 6 monthly, but unfortunately, it is not like a bone formative, it is more a anti-resorptive treatment. So, a dual treatment is okay, but where a bone formative treatment is warranted, better to go for the longer term teriparatide rather than giving a 6 monthly denosumab. So, we got to be very clear about that distinction.
Yep.
So that the patient should also understand how the actual treatment works. We do see sometimes there's a compromise on because of the compliance issue. But the compliance is very important because you got to first of all understand why we are going to give the formative therapy. The reason is to improve the bone mass by new bone formation. By giving anti-resorptive therapy, it may not work well. So that compromise should not be made. When the patient needs a formative therapy, better to go for a teriparatide.
And this is a long-term process. So even after we stop these injectable forms, again we might have to put them on further to prevent further bone breakdown. So it is not like okay, we have done this and now the bone is not going to break down anymore. But it's as we have been talking, it's an age-related process. So it will continue to the bone mass continues to deteriorate again. So therefore we have to again put them back on what you call like alendronic acid, or again some of the anti-resorptive agents, or the bone which prevents bone breakdown. So we have to again keep them on them, again monitor them. So this is a ongoing process. So so that the patient has to clearly understand that, and as doctors we clearly explain them is that this is a long-term problem, and along with lifestyle changes, yes, we can definitely make bone stronger.
There are a few common doubts when it comes to the treatment of osteoporosis.
Yeah.
One common question asked is it right for me to take the calcium in an elderly somewhere when they're over 60? And some patients may think that this can cause renal stones or can cause calcification in the blood vessels, it can cause heart issues, etc. But that is actually not true. There is no correlation when you look at all the research evidence. When you're taking calcium, it doesn't actually cause any renal stones or it doesn't cause any calcification in the vessels.
But
So
more than that, calcium, the compliance of taking a calcium tablets, as you all know, the calcium tablets are quite big ones, and just taking them orally, not expecting some renal stones or something are going to happen, but the tablet itself, taking them might be a bit irritant to your stomach, or sometimes it can cause constipation. So taking them might be a little difficult. So there are good calcium resources available in food form. You know, a lot of green leafy vegetables, and milk products, and even for vegans who don't take milk, there are like soya products, etc., which gives a good amount of calcium. So it is more of calcium absorption which is important than taking oral calcium. So that's why we supplement it with other vitamin D and magnesium sort of supplements to absorb calcium.
the other thing is when it comes to calcium supplements as well, there are different formulations. You can have calcium carbonate or calcium sulfate, or this calcium with magnesium combination.
Yes.
So we got to mix and match and see which the patient is actually able to tolerate well.
Correct.
So that is something you don't have to completely stop taking the calcium supplement. You can look into that. The other common question asked is, how long do I need to stand in the sunlight, doctor? So how long do you recommend to get enough vitamin D?
So the other important thing with sunlight is when compared to younger people to older people. So in younger people, exposure to sun really works because the skin absorption is really well. But as the age process, like even the skin cells are also kind of damaging. So as much as a younger person absorbs the sun converting into vitamin D is not as good as we grow older. So see, usually time factor, we say about half an hour to 40 minutes exposure to the sun. It doesn't mean you're covering the whole clothing and then you stand again is not going to help. And also, it is the early hour sun. It's not like the sun rays should fall, say for example, around 45 degrees or so, rather than falling vertically down like perpendicular, which is a during a midday. The sun rays are quite vertical, so they are only focusing on one area. So we want the absorption across the skin. So that's why we prefer early morning sunlight where the rays are little horizontal and the whole of the body is kind of exposed. Yes, sunlight is definitely, we all have to get exposed to sunlight. These days we are in AC houses, to AC cars, to AC offices. So we are hardly exposed to sun. Definitely sun exposure is very important. So we recommend half an hour to 40 minutes, I think, is if at all the timing is.
Yeah, if you look at a lot of websites, they say 15 minutes, 10-15 minutes in the midday, but actually that is meant for the Westerners whose skin is a bit more fair. And when it comes to our country, our population, I think half an hour to 40 minutes is a good time. That too in the morning hours would be better because our sun peak will be really hot. So better to go in the morning time.
Don't burn your
and
skin.
please don't use any sunscreens before you go into sunlight because it basically beats the need of the sunlight.
Yes.
So yes, there are very simple things to do to improve your bone health, to improve your bone density. Then if that is missed out and you unfortunately fall into the disease of osteoporosis, there are a lot of medications which can be given to get the bone density back to normal. But that's a very important thing to understand. So from AIG Hospitals, we have all the facilities. We have fantastic DEXA scan and all the equipment with multi-specialty model here. And we do a lot of screening programs for bone health as well. So with this note, I would say thank you for joining us. Thank you, Dr. Rajesh.
Thank you very much.
If you have any questions, you are more than welcome to get back to us. Thank you. Have a good day.
Thank you.